Good afternoon. I'm Madeline Helke, an RN at the long-term care facility.
And I'm Brianna, also an RN at the care facility.
And we're going to be going over a patient's med rec, and then we're going to be looking at specific items of polypharmacy with this patient's medications. So first of all, just to begin, we noticed that the importance of med recs and looking at the Beers criteria because frequently as patients get older, polypharmacy with different doctors and more medications because of higher increase of issues with the patient increases their risk for polypharmacy. So as nurses, our patient is first, and we want to keep them safe as possible and make sure that all the drugs given are working accurately and given with a purpose, not just being taken when they don't need to be taken anymore, because typically they can have more than one doctor. So we just, as nurses, want to help to be the middleman and keep the patient safe. And then this is also important when you're becoming a nurse because it will be a part of your everyday activity, going through meds with patients, teaching them about meds, teaching them about interactions and things with them. So we want to keep patient's safety always a priority as a nurse. And then with this specific patient today that we are going over, we chose case study 1, and we have Mrs. H, who is 72. She came in with her daughter today for a follow-up appointment. In the past 2 months, she's come in 3 times with gait instability and altered mental status. And the past time she was in, she actually was in with a UTI acutely, and then she was prescribed with nitrofurantoin. So we wanted to just look at that med and all of her other meds that she has been going on. And then Brianna, what did you find on her meds?
Okay, so I found that she has been taking 14 meds, or at least we have a list of 14. So I'm just going to go through each one a little bit and say if we think that she should continue taking it or if we have concerns. So the first one is the donepezil, and that's really for her dementia. She has a family or a past history of dementia. So that one is okay. We believe that that one should stay. The second one is the fluticasone propionate, and that's for her COPD, but we do want to watch because it does have an interaction with beta blockers, and she is on the metoprolol, and it also has an interaction with diuretics, like the furosemide that she's on. And then branching from that, we also want to watch because the furosemide and the beta blockers can cause blood sugar imbalances and hyperglycemic reactions, and she is a type 1 diabetic, so she's taking insulin lantus and insulin aspart. So we really just want to watch for reactions between those. She's also taking amlodipine, which is a calcium channel blocker for her heart failure history. And she's taking losartan, which treats kidney disease in diabetic patients. So this is an ARB, and we want to monitor the potassium levels because she's also, like we said, taking the furosemide, which will get rid of some of the potassium. She's also taking valproic acid, which is for seizures and bipolar disorders. And bipolar isn't really part of her past history, but she does have history of schizophrenia. So we kind of want to question this med and see if she still needs to be taking it, as well as the gabapentin, which is on our Beers criteria list. So the gabapentin also treats seizures and some neuropathy, but it is on the Beers list, so we want to take a look at that and maybe discontinue it. She's also taking quetiapine for schizophrenia and depression, which is a good thing because she does have the history of schizophrenia. She's also taking clopidogrel, which is an antiplatelet, also known as Plavix. And that's for her ongoing heart failure, so we decided that was a good thing for her to be taking, but we also wanted to monitor because there is a bleeding risk with that. She's also taking multivitamins and irons, which are good for her health and her heart. And then, like Maddie said, she's taking the nitrofurantoin, which is for the UTI, but that is on the Beers list because it can have side effects of pulmonary toxicity, hepatic toxicity, and peripheral neuropathy. So we would want to take a closer look at that and maybe get rid of it.
Mm-hmm. And going off what Brianna said, with all the things that she had come in with, we're going to especially want to monitor after her labs came back. We found that her A1C level was pretty high at about 8.1. So we just want to monitor that with the metoprolol. And then as she came in with the last UTI, And the medication that she was on, neferotin, that we noticed because it was on the Beers criteria, we're going to want to question that and perhaps ask her if she was still having those symptoms, and if she was, we would put her on a different medication for that, which we found that niprofloxacin would be the best one for that. It wouldn't interact with most of her medications, and it's not on the Beers criteria, which is great for a patient of her age. So that's what we do about that. And then there's also the question that her and her daughter don't really know the meds she's taking. They're not sure if she's taking them and all those type of things. So what we would do with that is we're going to call her physician. And then because she does live at an assisted facility where an RN comes in and sets up her meds, we would want to call the physician and get in contact with that RN and the facility, and then we want to set up a meeting, possibly with ourselves, the daughter, the patient, and both of them at the same time. That is really hard to come by, but I feel like it would be very beneficial for this patient, especially with all these meds that she's taking, all these issues that she does have in her past medical history and that she currently has right now. And then we would want to further talk about to the daughter and the patient because they did just switch doctors and they were feeling hesitant because the doctor tried to put her mom in a home and things like that, so that is probably a touchy subject, emotional there. So as nurses, we'd want to be really sensitive, but also advocate for the patient's safety, because with all of her altered mental status, being a fall risk because of her gait instability, we would want to further figure out if where she's living is the best for her. So we'd want to go over that lightly, ask the patient first how she would maybe feel about moving somewhere with extra help, not as being her independence taken away, but as more of helpful towards her. And then maybe the daughter can warm up a little bit more if her mom feels safer that way. So after looking at all these medications, hopefully we can get something worked out with this family, and hopefully this patient can be safe. Is there anything you'd like to add about this, Brianna?
No, I think that is all good.
All right, thank you.